This video, prepared for city leadership, focuses on reimagining Philadelphia's response to substance use. We will explore a public health imperative inspired by the Portuguese model, focusing on the crisis in Kensington and citywide. Philadelphia faces a devastating and evolving crisis. In 2023, the city recorded 1,315 overdose deaths, driven primarily by fentanyl and dangerous adulterants like xylazine. This tragedy is worsening racial disparities, with surging deaths among Black and Hispanic residents. The city's current punitive approach has been ineffective, with overdose rates remaining catastrophically high. We advocate for a paradigm shift to a comprehensive public health approach, inspired by Portugal's 2001 model of decriminalizing personal possession and redirecting resources to health interventions. While acknowledging implementation challenges, the Portuguese model's core principles offer a viable path. Our recommendations include piloting decriminalization zones, scaling evidence-based treatments, expanding harm reduction, reducing stigma through public education, and reallocating funds from punitive to health strategies. Section 2 focuses on Philadelphia's escalating overdose crisis, issuing an urgent call for systemic change. Philadelphia is among the large U.S. cities most affected by overdose deaths. The 2022 peak of 1,413 deaths and 1,315 preliminary deaths in 2023 underscore the insufficiency of current interventions. The 2023 overdose death rate of 78.9 per 100,000 residents is historically the highest among peer cities. Overdose death trends show that total deaths remain high. Fentanyl was involved in 83% of deaths in 2023. Xylazine involvement rose to 38%, and Black deaths remained elevated, indicating a persistent crisis. The lethality is driven by fentanyl, involved in 83% of overdose deaths. We also face a polysubstance crisis, as the combination of opioids and stimulants was present in 80% of deaths, reflecting co-use and a contaminated drug supply. Emerging threats include xylazine or tranq, involved in 38% of 2023 deaths and complicating overdose management as naloxone is ineffective. A newer threat, medetomidine or rhinotranq, is far more potent and causes severe withdrawal symptoms. The burden of the crisis falls disproportionately on communities of color. Between 2018 and 2022, overdose deaths increased by 87% for Black residents and 43% for Hispanic residents, while decreasing by 12% for white residents. While Kensington remains a center of the drug market, overdose deaths are a citywide tragedy affecting nearly every zip code. Beyond mortality, substance use disorder is linked with poverty, strains healthcare resources, and inflicts deep trauma on families. Section 3 examines the punitive status quo, focusing on Pennsylvania law and Philadelphia's enforcement reality. Pennsylvania's strict drug laws distinguish between simple possession and possession with intent to deliver, a felony. The extreme potency of fentanyl blurs this line, granting discretion to law enforcement and potentially criminalizing addiction itself. Philadelphia's enforcement trends show a notable uptick in arrests and charges in 2024. Despite these efforts, the crisis has worsened, suggesting that enforcement under the current punitive legal framework is not effectively mitigating the most lethal consequences of substance use. Criminalization comes at a high financial cost. State-level criminal justice system costs attributed to the opioid crisis were over $526 million. This heavy investment in punitive measures represents a significant opportunity cost that could be redirected to public health interventions. The human cost is immense. Drug arrests create lifelong barriers to housing and employment, trapping individuals in instability. Treating addiction as a criminal justice issue fails to address underlying drivers like poverty and trauma. Section 4 reviews Philadelphia's public health response, highlighting current services and systemic gaps. Philadelphia has a history of harm reduction, with Prevention Point Philadelphia operating the primary syringe services program. Access to naloxone is widespread, and fentanyl test strips are decriminalized, reflecting a fragmented embrace of harm reduction. The overdose prevention site controversy persists. Despite evidence that OPS prevent deaths, efforts to open one face legal and political blockades. The City Council's zoning overlay banning OPS creates policy incoherence amidst a deepening crisis. While a continuum of care is offered, gaps remain in treatment capacity and access. There is no real-time information on open treatment slots, limited recovery housing, and concerns about timely access to evidence-based care like medication-assisted treatment. Section 5 introduces the Portuguese alternative, a successful paradigm shift towards public health. In the 1990s, Portugal faced a devastating heroin epidemic. A national commission recognized the failure of existing punitive policies and recommended a paradigm shift centered on public health. Portugal's Law 32,000 decriminalized personal possession of small quantities of all illicit drugs. This is decriminalization, not legalization. Drug use remains prohibited, but users are diverted from the criminal justice system. Instead of court, individuals appear before dissuasion commissions or CDTs. This panel, composed of legal and health professionals, aims for dissuasion and health linkage. For problematic use, the focus is encouraging voluntary treatment. Decriminalization was paired with massive investment in health infrastructure. Funding for treatment and harm reduction increased substantially, with services integrated into the national health system, largely free of charge. The guiding principles include treating addiction as a chronic health issue, upholding human rights, and prioritizing harm reduction to pragmatically reduce death and disease. Section 6 examines the evidence from Portugal, assessing 2 decades of decriminalization outcomes. Public health outcomes were dramatic. Overdose deaths decreased significantly, remaining among the lowest in the EU. New HIV diagnoses among people who inject drugs plummeted, and more individuals voluntarily sought treatment without fear of arrest. The criminal justice impact included a reduced burden, with the proportion of prisoners held for drug offenses dropping significantly. Police were able to strategically redirect resources to investigating large-scale trafficking. The feared floodgates did not open regarding drug use prevalence. Problematic use and adolescent use often saw reductions, and Portugal's overall rates remain below European averages. The model is not without criticisms, and recent trends show challenges. A key driver was austerity, where funding for drug services dropped significantly, underscoring that sustained investment in health services is critical for success. Section 7 provides comparative insights, contrasting Philadelphia's current path with Portugal's experience. This slide provides a side-by-side comparison of the policy implementation in both Philadelphia and Portugal. Comparing outcomes, Philadelphia struggles with a worsening overdose crisis and widening racial disparities. Portugal achieved sustained reductions in deaths, reduced the criminal justice system burden, and fostered a health-focused approach that reduces stigma. Section 8 examines relevant lessons from Oregon's Measure 110, which serves as a cautionary tale. Oregon's implementation of Measure 110 faced hurdles, leading to a rollback in 2024. Key issues included funding delays, lack of coordination in police training, and implementation during external crises. The major lesson is that services must be built concurrently with legal changes. Section 9 addresses local concerns, aiming to build consensus in Philadelphia. A common concern is whether decriminalization will increase drug use. Evidence from Portugal, Oregon, and the WHO suggests otherwise. The focus must shift from prevalence to mitigating harm. Decriminalization does not mean abandoning public order. Public consumption can still result in sanctions, and existing nuisance ordinances remain. A public health approach ultimately enhances safety by connecting people to care. Section 10 presents our recommendations for charting a course toward health and recovery. Recommendation 1 proposes establishing pilot decriminalization zones in high-impact districts. Instead of arrest for simple possession, mandate citations requiring contact with a health engagement commission. This approach models Portugal while allowing local evaluation. Recommendation 2 is to create Philadelphia Health Engagement Commissions, or PHECs, as the administrative point of contact. These multidisciplinary teams will conduct non-punitive needs assessments, provide harm reduction education, and ensure seamless linkage to treatment services. Recommendation 3 is to scale evidence-based treatment, prioritizing rapid, low-barrier access to medication-assisted treatment like methadone and buprenorphine. We must expand mobile units and telehealth and implement a real-time database of treatment availability. Recommendation 4 focuses on expanding harm reduction. This includes scaling up naloxone and FTS distribution, protecting Prevention Point Philadelphia, and revisiting overdose prevention sites with robust community education on their life-saving efficacy. Recommendations 5 and 6 focus on public education and resource reallocation. We must launch campaigns to reduce addiction stigma and commission a cost-benefit analysis to shift funds from ineffective punitive measures to proven health strategies.